March 1st, 2024. That's the date. And this is the Room Now podcast. Hi, I'm Jack Cush, executive editor of RoomNow.com. Happy to be with you to discuss all matters rheumatology. But this week, a number of things I'm going to report are head scratchers to me. I don't know if these reports and associations are real or imaginary, luck or linked, casual or causal. I'm going to talk about links to weather, biomarkers, and infection, and you're going to have to decide for yourself. Don't take my inflections on this to be the end-all, be-all. If you're interested in the subject, go look at the source. Let's begin with a report about no clear link between weather and musculoskeletal symptoms. This is a fairly well done study, but it's a lot like a lot of other studies that have been done in the past. This was reported in seminars in arthritis and rheumatism, and basically the analysis that they did really showed no clear link between musculoskeletal symptoms and the weather. And, this has been looked at many times in the past, relationships to barometric pressure, humidity, temperature changes, latitude, longitude. It doesn't seem to matter yet. Patients will tell you they're way better at predicting the weather than is the weatherman. So who are you going to believe, the patients or the research? It's a little bit like diet, is it not? Lots and lots of studies showing really no effect of diet in spite of the many interventions, yet patients will swear that once they change their diet is when their arthritis finally got better. Interesting. An Australian study basically stated the obvious, but I think the obvious is worth stating again. This is a report where they looked at individuals who expressed a limitation in ambulation. So self-reported difficulties with mobility. They were patients who were limited to less than 1 kilometer were shown to have a higher risk of hip and spinal fractures, somewhere between 32% and 200% more. This is a study of over 239,000 adults over the age of 45, and the more limited, the more the risk of fracture. Many of these were, but not all of them were related to fall. And why is this worth, sort of obvious point, why is it worth stating? I think it's something we really don't pay attention to, meaning we don't protect our patients from falls. We don't deal with the issues of strength. We certainly know that people who have bad arthritis and people who are in pain are going to have problems with ambulation. They're going to have problems with falls. They may very well, because of their arthritis, have a risk of fracture. But I think that the underlying story here to me and to you should be we are probably not paying enough attention to strength. So if I was going to have a banner in my clinic, as I wanted to do but never got around to do it would be, this is the year of getting strong. Be strong and be well. And that means patients need to work out. They need to go to therapists. They need to get stronger. Because if they're not getting stronger, they're getting weaker. And if they're getting weaker, they're getting worse. Now, here's one of those head scratchers. The headline is, and this is from a journal that I don't subscribe to or pay any attention to. It's the American Society of Clinical Pharmacology and Therapeutics. It's a clinical and translational science report. The title is Machine Learning Identifies Fatigue in Fibromyalgia as being related to metabolism of tyrosine, purine, pyrimidines, and glutamine. What? So this is a study that looked at metabolic signatures that might distinguish fibromyalgia patients from control. 54 fibromyalgia, 31 controls. And they used machine learning, and they identified 13 metabolic markers that could accurately predict fibromyalgia with an accuracy of 79%. They showed clear correlations between 5-hydroxyindole acetic acid and glutamine levels with fatigue levels in FM patients. Is this a biologic correlate to the constitutional functional disorder, pain disorder that we call fibromyalgia? Is this casual or causal? I don't know what to think. It could be brilliant, and if it is, I'm taking credit for it. But if it's goofy, you'll forget it and won't blame me. An interesting review from a GI journal did a systematic review of patients with inflammatory bowel disease and showed that the risk of extraintestinal manifestations, and I must say in this report that involved over 61 studies and 13,000 patients, that the manifestations were largely articular and musculoskeletal. 8% risk of new joint findings in IBD patients starting advanced therapies like vedolizumab, ustekinumab, JAK inhibitors, TNF inhibitors, etc. So they basically found no difference in new joint findings, new onset incident joint problems. If you were taking either vedolizumab or ustekinumab, the risk of joint problems was 9% versus 6%, not significant. They also looked at the risk of joint symptoms getting better. And for the most part, there wasn't a lot of difference based on therapy, although drugs that you would typically say are good at arthritis, like JAK inhibitors and TNF inhibitors, were better than other drugs like vedolizumab, the integrin inhibitor. So that gives you a range of what you might worry about in an IBD patient, and what their risk of joint problems may be. If you were a pediatric rheumatologist, you probably would be familiar with the PAPA syndrome. This PAPA stands for pyogenic arthritis, pyoderma gangrenosum, and acne. This is an autoinflammatory syndrome due to a dominant mutation of PST-PIP1. That's proline, serine, threonine, phosphatase inhibiting protein 1. That's actually involved in CD2 T cell activation and cellular adhesion. It is this mutation in PST-PIP1 that leads to these pyogenic, pustular, neutrophil-laden, and joint disorders. But in this particular analysis that was reported in Annals of Rheumatic Disease, they found that this mutation was mediated by gamma interferon-mediated pyrin induction and IL-18 release. IL-18 being inflammasome release, just like IL-1 release, and moreover that this gamma interferon-mediated release of pyrin or activation and IL-18 release could be treated and inhibited by JAK inhibitors. So that's, I think, they're taking the science of this autoinflammatory disease to another level, and now it's relating to or having its benefits in the form of therapy. So inhibiting this gamma interferon-dependent feedback loop is beneficial in such patients. This past week, the FDA approved yet another adalimumab biosimilar. This makes adalimumab or Humira adalimumab number 1, and now we have 10 other adalimumabs in the form of biosimilars. This new one is called adalimumab RYVK, also brand name Sinlandi. Comes from Teva and Alvotech. It's different from the other adalimumabs in that it's the first of the new version of Humira, meaning it's high concentration, meaning less volume, and citrate-free, and it's also has an interchangeability component that other biosimilars don't always have. So it's getting busy out there in biosimilar land, is it not? Lupus, do you think it's going up or down? I think it's, from what I've seen in my career, it's always been a steady run. But an interesting study out of Norway was published in Arthritis and Rheumatology this month where they reviewed like over 3,000 patients with lupus, and they identified chart review proven lupus cases. And of the 1,500 plus patients, they identified almost 800 of them with new onset lupus between 1999 and 2017. During this period, the annual incidence rate of lupus fell. And it was most pronounced in women between the ages of 50 and 59, where the incidence fell during that period from 3 cases per 100,000 to 1 case per 100,000. Now, is this just Northern European white people? Would we be seeing the same rate where we really worry about lupus? And that would include, Hispanics, Asians, and African Americans, which are the more prevalent group. In this population, they also, in that same time frame, noted a 74% reduction in the use of postmenopausal hormone therapy. So a hyperestrogenic state might have been inducing some of those cases. It'll be interesting to see how, if other studies can compare. I personally don't believe that lupus incidence and prevalence is going down where I practice in Dallas, Texas. An interesting association was reported this past week between tocilizumab and the risk of infection. In this particular study, they showed that eosinopenia, low eosinophil counts, was associated with a greater risk of infection. Single center study, 163 patients, mostly RA, given tocilizumab. 41 were hospitalized, and half of those for serious infections. SIE rates were more common when eosinophil counts were less than 0.05 grams per liter, and when there was a low eosinophil to neutrophil ratio. Is this the way we're going to identify patients for infectious risk? Sounds like the math is too high or too hard to put to use. We're during ACR and during, I guess it was just during ACR, we talked about a new monoclonal antibody that has the potential to lower rheumatoid factor and CCP antibodies. It's a antibody against the neonatal FC receptor. But what you need to know about this is that while it's being studied in RA and Sjogren's, in 2021, the FDA approved a different antibody against the neonatal FC receptor, and the drug is called Vyvgart, or indication is for myasthenia gravis. In 2023, the FDA approved another drug called Rystiggo, also for myasthenia gravis, and it too is a neonatal FC receptor monoclonal antibody. And now we have the drug nipocalimab with promising results in RA, Sjogren's, hemolytic anemia, and also myasthenia gravis. This may be something worth watching. Again, the study reported at ACR showed numerically better clinical responses by ACR 20, 50, 70, DAS, whatever, but they weren't significant and didn't meet its primary endpoint. It did significantly lower ACPA levels, but those studies were really pilot studies and underpowered as far as the number of people that were included. I think it's an interesting area of drug development you might want to be watching. There's a great Spanish RA registry called biomarkers, and they did an analysis that looks a lot like the data we've seen coming out of the Mayo Clinic. And they looked at the incidence of multimorbidity and what its effects were on RA outcomes. So their study of 1,128 patients going on either a biologic or targeted synthetic, and they found that about 10% met the definition of multimorbidity with a Charlson comorbidity index of 3 or greater. Multimorbid RA patients were older. They had more swollen joints. They had significantly higher DASH 28 scores And it didn't seem to affect their retention rate on drugs. But the point being that comorbidity adds to severity, makes optimal outcomes more difficult to achieve. Two more reports I think that were really eye-catching to me. One comes out of Toronto in the Journal of Rheumatology. Daphne Gladman's group reported that psoriatic arthritis patients may not easily achieve the target goal of MDA, minimal disease activity. So this was a study of almost 1,600 adult PSA patients, and they had all kinds of measures. And this was a multi-center study throughout Canada. And the patients included were those starting on new advanced therapies. And what do you think the percentage of those failing to achieve MDA at 6 months? We think, I don't know. Well, I was surprised at these numbers. It's 65% in Ontario, 68% in Western Canada, 75% in Quebec, and 75% in the Atlantic and Eastern region. Meaning 25 to 35% of patients are not achieving MDA. Now, are we not giving them enough time? Are we not treating them aggressively? Do we need to rethink our goals and our initial treatment choices in PSA? I think that this is food for thought. Another eye-catching, headline-grabbing news piece appeared this week where sinusitis is linked to a 40% increased risk of rheumatic disease. Really? The sniffles, a snotty nose, sneezing. What? Well, this study comes out of the Mayo Clinic. 1,700 plus patients followed for greater than 5 years. There was this 40% risk. And what kind of rheumatic disease are we talking about here? Were they all Wegeners? No, they were not. The greatest risk was for antiphospholipid syndrome, a 7-fold higher risk. Sjogren's syndrome, 2.5-fold higher risk. Vasculitis, a 40% increased risk. Same for PMR, a 40% increased risk, and a 80% increased risk for seronegative RA. I don't get this. I don't even know if this really means anything. Everybody gets sinusitis, or, every 2/3 of patients with fibromyalgia have sinusitis. 1/3 of RA patients in my clinic report sinusitis. But what they reported was that this increased the risk. If you had repeated episodes, your risk was increased. Acute sinusitis was associated with the risk of seronegative RA. I might buy the idea that sinusitis could increase the risk of RA, as that would go along with the mucosal hypothesis behind RA, that upper respiratory infection and or endothelial activation leads to ACPA generation, and microbiome changes do the same. But that's with seropositive RA. They found an association with seronegative RA. Again, a head scratcher. Is it real? Is it imaginary? Does it mean something to you, or am I wasting your time? Let's end with an Ask Cush Anything, a question I received 2 weeks ago from Dr. Nicole Melendez in Tampa. She asked the question, I have several young RA and PSA patients asking if there's any risk when they have a child that the child will have health problems related to their RA. And there's some concern about autism. And in general, we do know that there are some risks to adverse pregnancy outcomes in mothers with RA, higher rates of premature birth, high rates of miscarriage, spontaneous abortions. Not clear that higher rates of fetal malformations, right? But this is part of the reasons why we strongly recommend your RA patients be totally controlled, in great shape. You don't want to go into making a baby in an inflammatory milieu, right? The question of autism is even more complex. The risk of autism and autism spectrum disorders is somewhere between 1.5 and 3% in the general population. RA patients do the same. I found a report, I actually reported this earlier this year. It's from Psychologic Medicine that says that in maternal RA, there is no increased risk of autism in the offspring unless the mother has RA before she becomes pregnant. So this is a study of 3,600 RA mothers compared to 1.5 million other mothers without RA. The risk of autism was the same in both, and not any different, 1.9% in both groups. That, as I said, is equal to what the population number is. But they did find that if the mother had RA before delivery, the autism spectrum disorder risk was significantly higher at 1.43 hazard ratio, and especially higher for seronegative RA, 1.61. Those numbers were significant. But are they meaningful? Let's talk about meaningful numbers here. Again, 3,629 mothers with RA who were pregnant. They gave birth to 78 or 70 with autism. And again, the rate there is 1.9%. I think that these numbers aren't worth scaring your patients about. Now, if the patient is uniquely tuned into the whole autism risk because it's a family risk, well, that will carry an increased risk by itself, will it not? This is somewhat heritable. So I think these are muddy waters. I think the risk is really low. I don't have these conversations with my patients. I tell my patients, young patients with RA and PSA who want to get pregnant, let's be in remission and then let's get pregnant. And that's how you make a baby. Hope you enjoyed the podcast. Go to the website to check out these citations and more. We'll see you next week on the podcast. Take care.